now. As far as strokes go, we've talked a little bit about caring for someone after they have had a stroke or identifying signs that someone might be having a stroke. But what exactly happens when someone has a stroke? So, when someone is having a stroke, a part of the blood supply to their brain is blocked, or part of the vessel has ruptured and there's bleeding occurring in the brain. As we've talked about, following a stroke, a resident can have lasting effects like paralysis, weakness, difficulty with their speech, swallowing, as well as control of their bowel and bladder. What's interesting about a stroke is that a stroke that occurs on the left side of the body affects, or the left side of the brain, affects the right side of the body, and vice versa. So if the stroke occurs on the right side of the brain, it affects the left side of the body. So you can usually tell which side of the brain someone has had a stroke on if they have lasting effects on the right side versus the left. Like we talked about before, early intervention or the severity of a stroke being more mild can result in few or no complications at all. When we're caring for someone who has had a stroke, we've gone through all of these things before. A couple things I want you to remember. We use terms like involved, affected, or weak side. We don't apply any negative terms to that side. Keep in mind, we need to help the resident adapt to any limitations they may be experiencing, promoting their independence as long as it is safe to do so. For someone who has weakness or paralysis on one side, we need to be checking body positioning, alignment, checking the skin, because if there is no feeling on that side of the body, the resident is likely not going to have those warning signs like something is painful if they've been in the same position for too long. Residents with lasting effects, we're going to stand on and support the affected side of their body. We always want to lead a transfer with the stronger side. Remember, when we're dressing them, we dress the affected side first, but when we're undressing them, we undress the stronger side first. There's a lot of different adaptive equipment, wheelchairs, utensils, plates, cups, etc., that can be used to help these residents. And if they have any difficulty with swallowing, they may be on a modified texture diet as well as thickened liquids. Parkinson's disease and MS, we've touched a little bit on Parkinson's, not a whole lot on MS. So Parkinson's disease is the one I was talking about where residents may experience tremors. Tremors are uncontrolled shaking, typically in the arms, make it really difficult for them to do ADLs like feeding themselves, getting dressed. Parkinson's disease causes a stooped posture and also a shuffling gait. So instead of picking up their feet to walk, they tend to scoot the feet across the floor. A lot of times it results in a masked facial expression. So kind of just like straight-faced all the time, not a whole lot of expression. What occurs when someone has Parkinson's disease is continuous breakdown or degeneration of different sections of the brain. So Parkinson's, sometimes you'll see with the diagnosis that they have Parkinson's-related dementia. Unfortunately, with Parkinson's disease and deterioration of certain parts of the brain, that can also lead to dementia. So you might see that as well. And then pill rolling is a type of tremor that can occur. It almost looks like someone is trying to roll a pill between their fingers. So it's this sort of motion that you'll see them do. Why it's called pill rolling, I'm not exactly sure, but it mimics them kind of trying to roll something in their fingers. Again, a type of tremor. When you're taking care of someone who has Parkinson's, protecting them from falls, especially since their posture becomes stooped and also their gait is shuffling. They're at an increased risk for falls. Assisting with range of motion, ADL care, reporting and observing observing and reporting any issues. Again, encouraging independence, being patient. As long as someone is safe to do something independently, doesn't matter how long it's going to take them. Moving on to MS. MS is also progressive. Again, no cure for MS. What happens when someone has MS is it's diagnosed through a brain MRI, and the telltale sign is when the myelin sheath, which is the covering over the nerve cell, starts to deteriorate. So let's look at what that would look like. So the myelin sheath itself, it's kind of like insulation for the nerve cells. And what the insulation does is it promotes the nerves to be able to transmit between one another. So the nerve signal goes from one nerve to the other, and that allows for the process of our message center to control our bodily function. But when that insulation or that myelin sheath is damaged, those nerve messages are unable to get through to the next nerve. So you can see on the left, that would be like a healthy nerve cell. That myelin sheath is pictured in blue. On the right, that would be a nerve that is affected by MS. So that myelin sheath is deteriorated and broken down. So that nerve is not able to transmit its impulses to other nerves. So the chain of communication in our message center is broken. What's interesting with MS is that the level of ability for someone who has MS varies very widely. It depends on the person. Some people have changes to their abilities pretty quickly, pretty early on. Some people don't experience these changes to their abilities until later stages of MS. So it really depends on the individual. Symptoms can range from issues with balance, to blurred vision, to numbness and tingling, to lack of bowel and bladder control or incontinence. The main issues when someone has MS include functional issues, so loss of ability to move the arms and legs independently, can lead to atrophy of the muscles, contractures. Also, due to the issues that it can cause with vision, it can lead to blindness. So knowing each individual's abilities is very important. For example, I've taken care of a resident who has such severe MS that they cannot stand, walk, control bowel or bladder, don't see very well, basically can verbally communicate some things, but some of those thoughts are very clearly impaired. Whereas someone else who I've taken care of with MS is independent in their mobility, their ADLs, various other things. So those differing abilities really depend on each resident. So pay attention to their needs, pay attention to their individual abilities. Make sure if you notice the care plan says one thing, but you're seeing something else, that you report that to the nurse. Symptoms with MS can change pretty quickly. Questions so far? All right. Then moving on to different types of paralysis. So the terms here on your screen, paraplegia and quadriplegia. Paraplegia, if someone is paraplegic, they do not have function in their lower body, so typically both of their legs. Quadriplegia, the term quad, Q-U-A-D, means four. So quadriplegia involves not only the lower limbs, but also the arms, typically some involvement in the trunk as well. So, what causes someone to be paralyzed or to be para or quadriplegic? Typically, some sort of head or spinal cord injury that could result from numerous different things: motor vehicle accidents, falls, sports injuries. Lots of different things can cause a head or spinal cord injury. These injuries can cause issues with personality, so changes to the personality, intellectual disabilities. Also, depending on the area that is impacted, breathing problems, our respiratory control centers in our brain, seizures, issues with memory, paralysis, coma, as well as loss of consciousness. So the lasting effects are going to be dependent on the force of the impact and also where on the spine the impact actually occurs. Emotional support and rehabilitation are extremely important with head and spinal cord injuries. Other things to keep in mind, someone who has had a head or spinal cord injury is at an increased risk for falls, for skin breakdown, for having issues with different types of healing, so at risk for atrophy. They're at risk for fluid complications, dehydration, fluid overload, nutritional issues. They're also at risk for infections, like we talked about when someone is immobile, things like upper respiratory tract infections, urinary tract infections. Really important when someone is healing from a spinal cord injury that we provide them frequent rest periods. They typically experience excessive fatigue. One thing to keep in mind, if someone has had a head or spinal cord injury that has interrupted their communication between the nervous system and the bowel or bladder, they may become incontinent. So those bowel and bladder retraining programs that we talked about can be very useful for this. Another thing to keep in mind is there are a lot of involuntary behaviors, emotions, things like laughing or crying at inappropriate times that can occur. Also, with our male clients, really important to know that involuntary erection is a thing that happens. And just like we talked about before, we don't ever want to, scream or make some sort of inappropriate notion like laughing at someone if this does occur. Very important to provide privacy and to know that this is based on a disruption in that spinal cord, that main communication with our body. Epilepsy, we already talked about. Remember, epilepsy causes seizures, but not all seizures are a result of someone having a diagnosis of epilepsy. Seizures can range from mild to violent. Sometimes the cause is unknown. Sometimes the cause is an illness or injury, for example, a head or spinal cord injury. Usually we use an EEG, an electroencephalogram, to detect if there is some sort of disruption in the electrical impulses of the brain. And then based on those results, based on what we know about previous seizures, there are different medications or surgical procedures that can help with that. Eye conditions, there are a lot of them. I don't expect you to know about each one in depth. What I want you to know is that there are different things that can happen to our eyes as a result of aging. There are different things that can happen to our eyes as a result of pressure imbalances or injuries. And also, there are things that, based on other medical conditions, can start to occur with our eyes as a result of those conditions. So things like, for example, diabetes. Diabetes has a very negative impact on the vision, very negative impact on the retina in the eye specifically. So diabetics, ultimately, if blood sugars are not well controlled, can become blind. So don't expect you to understand each of these definitions here. What I want you to know is if your resident has an issue with their vision, what is it? Are they unable to see clearly? Can they not see close up or far away? what is the issue with their eyes and how are we going to help them with that issue. So as we previously talked about, if someone has a visual impairment, they may need glasses, they may need contact lenses. They may need us to describe using a clock face where on the plate their food is. We never want to move anything in their room. So like rearranging things can be really confusing because oftentimes they use muscle memory and touch to know where things are. So if you're going to move something, make sure that you verbalize that and you let them know. Any questions about those nervous system disorders? All right. I know this is like the world's longest chapter and lots of conditions. So if you don't remember what each one is, that's okay. Just to give you an idea of what you might see. That's why we're looking at these. Moving on to the circulatory system, we talked about hypertension being high blood pressure. So when we check someone's blood pressure and it is higher than the normal limits. One thing that can result when someone has chronic hypertension, meaning that their blood pressure remains high for an extended period of time, there can be different effects on the vessels in their circulatory system. Things like atherosclerosis, which is a hardening, narrowing of the blood vessels, can occur. With hypertension, hypertension paired with something like diabetes, for example, can be really detrimental to the vessels. There are also other factors, dietary factors, for example. Fatty buildup can occur inside of the vessels, which either can cause the blood pressure to be high as a result of decreasing the amount of space in the vessel that the blood has to flow. Kidney disease, as we talked about, we can have kidney disease that can increase blood pressure. As far as other causes, tumors, especially on the adrenal glands, can elevate our blood pressure. If you're not familiar with the adrenal glands, let me show you in this picture. We had a picture of it way back in our crash course on anatomy. But the reason that adrenal tumors can cause hypertension is because the adrenals actually lay right on top of the kidneys. So they look like this. So those two little, almost like hats on top of the kidneys are our adrenal glands. So that can result in hypertension. Sometimes pregnant moms get hypertension as a result of the pregnancy, typically resolves after childbirth. And then there are certain medications that may have a side effect of hypertension as well. Everybody else still there? I got kicked out. And then it was like, you've been removed from the meeting. And I was like, but I have to be in the meeting. All right, that was weird. That has not happened before. All right, so I was talking to myself about hypertension. So now I'll talk to you because that makes more sense. All right, so when someone has hypertension, a lot of the times the only reason they know that they have hypertension is because we check their blood pressure and we tell them it is not within the normal limits, it is high. Other times they may have symptoms related to that high blood pressure. Those are usually things like dizziness, headache, vision changes. If those sorts of symptoms were experienced, we would report them to the nurse. We might also want to grab a set of vital signs, check the blood pressure, see if it's running high. But like I said, a lot of times they don't have any idea until we tell them, hey, your blood pressure is high. And they're like, oh, yeah, it was high last time too. Or, oh, I didn't know. So that's pretty common for people to be what we call asymptomatic, not having any symptoms. When someone does have a diagnosis of hypertension, they may be on a special diet, heart healthy diet, which is low sodium. They may be on an exercise program. Usually we're taking vital signs daily, if not twice a day, before they receive their medication from the nurse. We'll get into different medications that can be used for blood pressure. Some of these medications help to decrease the fluid level, so oftentimes increasing the frequency of them needing to urinate. So helping them to the bathroom is very important. All sorts of different terms here. We'll go through each of them. So starting out with what's called coronary artery disease. Remember when we talked about the heart and I showed you the coronary arteries, which actually supply the heart with blood? So the coronary arteries can become narrow and restricted, which can result in what we call angina or chest pain. Remember that the cause of a heart attack is actually a blockage of one of these coronary arteries, so that blood supply is not getting to the heart. So coronary artery disease can cause, in turn, a heart attack. If someone is experiencing angina or chest pain, we want to make sure that the nurse is aware of that symptom. We want to encourage them to rest. Some residents experience angina frequently. They may be taking a medication called nitroglycerin to help with that. Nitroglycerin comes in the form of a patch, a pill. It comes in the form of a cream as well. So note, if your resident does have a diagnosis where they do experience this and they are taking nitroglycerin, note that if it's in the form of a patch and that patch comes off, we want to alert the nurse so that the patch can be replaced. Also know that if someone is frequently experiencing chest pain, there are a couple of things that we can do to help decrease that severity. Things like avoiding extreme heat and extreme cold, avoiding intense exercise, and also large, heavy meals. All of those things can increase the stress on the heart and those coronary arteries and increase the likelihood and severity of chest pain. Heart attack we already talked about. If you want to look at that again, it was in chapter 7. Moving on to congestive heart failure, or CHF. What happens with congestive heart failure is the heart muscle itself becomes an ineffective pump as a result of damage to the structure. With that damage to the structure, the resident typically feels really tired or sluggish. Their heartbeat usually becomes irregular. They may have difficulty breathing, feeling dizzy, and all of this ultimately is a result of fluid buildup. So like we talked about yesterday, they're going to have that edema or swelling in the feet and the ankles. They may be on daily weight checks because if they gain weight, that's a good indication that they're retaining fluid. And the reason that they have excessive fluid buildup in the system is because their heart is not functioning properly to distribute through the circulation, to move blood throughout the system, to collect waste products, and then ultimately get rid of those waste products. So the medications I was referring to when we talk about treating heart conditions that can cause a resident to urinate more, the reason for these medications is for something like CHF, where there's excessive fluid buildup and we need to get those fluids off of the body so that we're not causing any further damage. So medications that help with CHF ultimately increase the output, so urinary output. These residents may also be on a fluid restriction. If they're on a fluid restriction, follow that very closely. We would need to monitor their intake and output. Like I said, they may be on daily weights, reporting to the nurse if there is a change in the weight. They may need additional pillows to prop themselves up to promote breathing. Usually, breathing is difficult lying down, again, because their heart is not effective. It is not pumping out their blood to the circulatory system effectively. Peripheral vascular disease, or PVD, what happens here is there are little deposits of fat that get stuck inside of the blood vessels and they harden in place. So it's almost like little speed bumps inside of the blood vessels. So what happens when there are obstructions in the vessels is the blood cannot circulate around the body effectively. So this causes things like feeling cold hands, arms, feet, legs because of that poor circulation. The nail beds becoming like a blue color. So if you've ever seen someone who has really cold hands, if you look at the base of their nails, you can usually see a discolor, like a gray-blue color. Swelling, pretty common as well due to the lack of venous return to the heart, as well as skin breakdown, usually of the extremities that are cold. So the legs, the feet are more common. Those areas are also what we call dependent areas, meaning that gravity works against us and allows for edema to pool in those areas. So usually when you see edema, it's in the dependent areas of the body, like the lower legs. For someone who has PVD, those anti-embolic stockings, compression socks, TED hose, whatever you want to refer to them as, can be very helpful in helping to return that venous circulation back up to the heart. So we'll take a look at how to apply those stockings. And you'll get to practice this in clinical as well. See if I can find the video. Here we go. And this video is only going to show application of one stocking, but usually if someone has something like a circulatory disease, it would be putting the anti-embolic stockings on both legs.
Hi, Mr. Bragg. My name is Betsy. I'm your nursing assistant today, and I need to put your elastic stockings on today.
Privacy is provided with a curtain, screen, or door.
Privacy? Would wash my hands?
After the client is in supine position, the stocking is applied. The candidate turns the stocking inside out, at least to the heel. The foot of the stocking is placed over the toes, foot, and heel. After, the top of the stocking is pulled over the foot, heel, and leg. All the while, the candidate moves the foot and leg gently and naturally, avoiding force and overextension of limb and joints. A critical step, the candidate finishes the procedure with no twists or wrinkles, and the heel of stocking, if present, is over heel, and the opening in the toe area, if present, is either over or under the toe.
Bed is locked. Bed is low.
After ensuring the signaling device is within reach, they ensure the bed is in low position.
Would wash my hands, and this goes complete.
All right. Yes, Irene.
But we don't have to wear gloves while doing that?
You don't have to unless there is any risk of exposure to bodily fluid. So if they had a wound or an open area on their skin, I would. Personal preference, I like to wear gloves because older adults tend to have dry, flaky skin. And when you remove and put on those elastic stockings, a lot of times you get a little storm of dead, flaky skin cells. So I would prefer those be on my gloves and not on my skin. That's just me. But if there's no risk of exposure to body fluid, you don't need gloves. Good question. Also, keep in mind, like everything else in healthcare that comes from different manufacturers, there are different types of TED hose, of course. There are ones that are open-toed. There are ones that are closed-toed. There are ones that have a different colored area for the heel and the toes so that you know exactly where to put them. So know what your resident has and know how to use that specific TED hoe. Unfortunately, different manufacturers do different things and it gets a little confusing. But you'll be able to see a wide variety of different TED hose as you go caring up for residents. Any questions about that video? All right, moving on to the respiratory system. Lots of different conditions can occur with the respiratory system. When we look at older adults, COPD, chronic obstructive pulmonary disease, is one that you might see. It is, as it says in the name, chronic. Residents who have COPD have difficulty breathing, especially feeling like they cannot get air back out of the lungs. So it's not that they can't get a breath in, it's that they can't get that breath back out. There are two diseases grouped under COPD. Those are chronic bronchitis and emphysema. Anyone who has the COPD as a diagnosis is at a higher risk of contracting a respiratory disease called pneumonia. So pneumonia, typically a bacterial infection that requires antibiotics. When someone has COPD and they are not adequately perfusing their tissues with oxygen, the tissues and systems that are involved are throughout our entire body. It's not just the lungs. When the brain is impacted, so impacted by not getting enough oxygen, that can lead to symptoms of or very similar to dementia. Residents who have COPD tend to have a fear that they're not going to be able to breathe. The best way to promote breathing for these residents is to allow them to sit in an upright position, which improves their ability to expand their lungs. A lot of times laying down, they can't get that full expansion. As a result of COPD, residents tend to have a poor appetite. They also tend to have issues with sleep. So that can lead to further issues with the brain and with the rest of the bodily systems. Symptoms for someone who has COPD, typically a chronic cough, coughing things up, fear and anxiety around breathing, again, confusion as a result of the lack of oxygen to the brain. They may also get that cyanotic appearance to their skin if the skin is not receiving adequate oxygen perfusion through the circulation. For these residents, most important things we can do, infection prevention. Remember, they're at a heightened risk of infection. Help them to promote breathing, like I said, sitting up, upright position, or a forward-leaning position. We call it a tripod. So putting their elbows on maybe the overbed table and then leaning forward can help them to breathe. Offering plenty of small meals. Large meals tend to increase the difficulty with breathing. Usually these residents are on an additional supply of oxygen, so making sure that their oxygen is on, not only on as far as the machine or tank, but also on as in they're wearing the oxygen device. Encouraging independence, but allowing for frequent rest periods. Another thing we can do with these residents, if they're having difficulty getting air out, is we can have them practice what's called pursed-lipped breathing. So it's almost like if you took a regular breath in and then put your mouth like you were drinking out of a straw and took a breath out. So not allowing as much air out at a time as you normally would with breathing. That can help them to feel like they're controlling the amount of air that is coming out of their lungs. So that helps sometimes, not all the time. We would want to make sure to report any issues with confusion, with their breathing, with any changes to any of their abilities, or with any signs of infection. All of those things need to be reported to the nurse. Moving on to asthma. Asthma can be seen in older adults. It's usually seen earlier in life, starting out in childhood, maybe early adulthood. So asthma is a chronic inflammatory illness that occurs when the respiratory system becomes hyperactive, usually as a result of some sort of allergen or irritant or infection. When someone has an asthma attack, their bronchi constrict, which makes it difficult to exchange air. Things that can make asthma worse include exercise. So if someone has exercise-induced asthma, also stress. If you haven't noticed already, stress makes every medical condition worse. Asthma causes coughing and wheezing. The exact reason that someone gets asthma is unknown. We know that there are different things that can cause asthma, but why it happens to some people and not others, nobody really knows. Treatment for asthma is to avoid the trigger. So if it's an allergen, avoid that. If it's exercise, avoid excessive exercise. Also, medications in the form of an inhaled medication or a spray. So typically people will have what's called a rescue inhaler. In case they have an asthma attack, they can use that inhaler to help open up their airway. Moving on to bronchiectasis. Bronchiectasis is a condition where the bronchial tubes are permanently enlarged, usually seen in earlier childhood. It can also result from infections and chronic inflammation later in life. One common cause that we see in children is called cystic fibrosis. Bronchiectasis causes a chronic cough, recurrent infections, and also weight loss. And treatment is infection prevention, preventing complications from occurring. May also include things like antibiotics and what's called postural drainage. So I'll show you a picture of what this process looks like. Usually with postural drainage, this is done either by a respiratory therapist or a nurse. And it's a special way of positioning the person to promote drainage to come out of the lungs. So for example, here is a picture of some different positions that residents may be put in to help to resolve that drainage, to help to get that drainage out. So the nurse or respiratory therapist would determine where the air or where the changes in breathing are heard. So they would put on their stethoscope, they would listen to different parts of the lungs. They could usually determine based on the sounds that they're hearing if there's some sort of fluid buildup. Based on where that fluid buildup is, they can put the resident into different positions to promote drainage of that fluid. So it looks simple, right? Like you just lay them on their side, but you have to be able to assess where that fluid is building up and also what position is going to best release that fluid. So it's quite a science. Upper respiratory infections, these are things like our common cold. They're typically a result of either a virus or a bacteria. Remember, bacteria require treatment. Viruses will eventually die off on their own. Symptoms of an upper respiratory infection are coughing, sneezing, fatigue, sore throat, fever. Usually, if it's viral, rest, fluids, medications to help with symptoms are the most effective. If it's bacterial, typically going to need an antibiotic to get rid of it. Any questions so far? All right. Moving on to lung cancer. When someone has lung cancer, they have abnormal cells or tumors that develop in their lungs. Usually the symptoms that we see with lung cancer is coughing up blood, difficulty breathing, also chronic coughs that don't have any other reason. Like they're not sick, they don't have an upper respiratory infection, but they're still coughing. And we'll talk more about cancer in general at the end of the chapter. So one thing that I want to go over with you, where would you go? There we go, is collecting a sputum specimen. So we talked about collecting urine specimens. We talked about collecting stool specimens. You can also collect a sputum specimen to test the secretions that are being coughed up from deep down in the lungs. Collecting a sputum specimen is one where you might want to wear additional PPE, maybe a gown, mask, in addition to your gloves. If you're afraid that maybe the sputum is going to get in your eyes, maybe some goggles as well. One very important step in collecting a sputum specimen is that we need to collect this specimen at a time that is not around when the resident has eaten or drank anything or brushed their teeth. Reason being is we need them to cough and produce secretions out of their airway. If they have eaten, drank anything, or brushed their teeth, we're going to probably be collecting some remnants of that food, fluid, etc. So the best time to collect a sputum specimen is first thing in the morning, before they get up. We also need to make sure that when we are collecting this specimen, that the resident knows we're trying to collect those secretions that are deep down in the lungs. So we need them to do a big cough to get some of that stuff up. We're not just looking for them to spit the saliva that's in their mouth into the specimen collection container. Keep in mind, if we're checking a sputum specimen, usually we're looking for infection. So please protect yourself, wash your hands appropriately. Moving on to the endocrine system, we already talked about diabetes, so we won't go too in depth on that again. The only thing I want to bring to your attention is the different types of diabetes. Diabetes can be what we call juvenile or type 1 diabetes. Type 1 diabetes is something that is usually noticed pretty early on in childhood and continues throughout someone's life. So it is a chronic condition. What happens with a type 1 diabetic is that their pancreas does not produce insulin. So there's not enough insulin to transfer the sugar in the blood into energy for use by our body. For type 2 diabetes, this one's a little bit different. Type 2 diabetes is not a chronic condition. It is not something that we detect early in childhood. It is typically diagnosed in later ages, like 30, 35, 40, all the way up into older adulthood. It's a milder form of diabetes than type 1. What happens with type 2 diabetes is typically an extended lack of attention to diet and exercise, which puts a lot of stress on the pancreas, which does not allow the pancreas to either produce enough insulin to be effective, or the body does not know how to use the insulin that is formulated by that pancreas, and therefore the insulin is useless. With type 2 diabetes, typically management is diet and exercise, along with some oral medications, and in some more severe cases, maybe administration of insulin as well. Before someone is deemed a type 2 diabetic, there's typically a lot of warning signs. Usually, annual lab checks can give a lot of information to the doctor on glucose levels. Typically, information related to diet and exercise gives a lot of information to the doctor on glucose levels. When someone is not quite a type 2 diabetic, but they are quickly approaching, the doctor will usually let them know that they have a diagnosis of prediabetes. So what that means is that if they continue on the current pathway of diet and exercise, their blood glucose levels are going to continue to be abnormally high. With the blood glucose levels, we can check a glucose level randomly, like right here, right now, what is the glucose level? We can also check what's called an A1C, which is an accumulation of the glucose levels over the last 3 months. So if the doctor checks an A1C and those glucose levels over the last 3 months have been high, that's a pretty good indication that someone is pre-diabetic on their way to becoming a type 2 diabetic. In my experience, a lot of times that prediabetes diagnosis really sets off the light bulb, and people tend to then watch more of what they're eating or try to incorporate more exercise into their life, and then hopefully prevent themselves from becoming type 2 diabetic. Another thing to note with type 2 diabetes is once someone is diagnosed with type 2 diabetes and maybe they require medication, they can alter their diet and exercise and return their blood sugars to a more normal level and maybe get off of those medications, get off of that supplemental insulin. So it doesn't mean that they won't be diabetic any longer. They'll always be considered a diabetic after that, but they can kind of revert back to not needing those additional treatments. Another form of diabetes that we can see, so the third form, is called gestational diabetes. Gestational diabetes is a type of diabetes that is only present in a woman when she is pregnant. Does not mean she was diabetic before. It also does not mean that once the baby is delivered, she will continue to be diabetic. So there is no link to that. It's just during pregnancy. If you have ever been pregnant and you have had a glucose tolerance test at the doctor's office, they're checking you for gestational diabetes. So they're checking to see if your pancreas is producing enough insulin and your body is using that insulin properly to transmit the glucose in your blood into energy that we can use for our body. So we already talked about signs and symptoms of diabetes, so we won't go over that. But complications, we talked a little bit about this with visual impairments. Complications of diabetes are widespread. So think about if your pancreas is functioning properly, it's producing insulin. That insulin is taking the sugar in your blood and making it into energy, and then you use that energy. All of your systems are able to function properly. If your pancreas is not producing insulin, or your body doesn't know what to do with that insulin, the buildup of glucose in your blood that is circulating around your body has detrimental effects on all of your other systems. So that high level of glucose in the blood damages our vision, it damages our circulatory system, it impairs our ability to heal, so wounds heal very slowly. It causes damage to the nervous system, damage to the kidneys. Also, as a result of that impaired wound healing, there's an increased risk of infection. If there is a lot of sugar, sugar feeds infection. So glucose circulating in the blood helps to aid in infection being successful. So wounds can become infected. That can lead to maybe the need for amputation. Caring for someone who is diabetic, really important to follow dietary instructions. A lot of times they're on a carb-controlled diet. Encourage exercise. Maybe testing the urine, for example, to see if there's glucose. Diabetic foot care is really important. So making sure that if you notice any cuts, sores, redness on the feet, that gets reported to the nurse. And like I said, for all residents, if they're out of bed, we want them in non-skid footwear. Especially for diabetic residents, we want to make sure that they have socks that are breathable and shoes that are going to protect their feet. Since diabetes can damage the nervous system, they may experience what's called neuropathy, which inhibits their ability to feel in their distal extremities. So the feet is usually the first place that occurs. So providing foot care to a diabetic resident as opposed to a resident who doesn't have diabetes, just need to be really careful and again, report anything that you observe. Remember when we talked about and looked at the video, lotion should never go between the toes. If it does, accidentally, just wipe it out with a towel. Any questions on diabetes? All right. Other endocrine disorders. Our thyroid gland is one that tends to give people issues. It can either produce too much hormone or not enough hormone. So if someone has hyperthyroidism, it means that their thyroid is overactive. It is producing too much thyroid hormone. Too much thyroid hormone speeds up all of our bodily processes. So it causes weight loss because it speeds up metabolism. It causes a rapid heartbeat, tends to put someone into almost like a fight or flight mode, so feeling nervous and sweaty. Usually for hyperthyroidism, it can be tamed or calmed down with a medication. If that doesn't work, part of the thyroid gland can be removed to help decrease the amount of thyroid hormone that is being produced. On the opposite end, hypothyroidism is where the thyroid does not produce enough of the thyroid hormone. Therefore, everything slows down. So weight gain, constipation, fatigue, intolerances to temperature extremes, as well as all of our vital signs being low and slow, so low blood pressure, slow pulse. This can also lead to hair loss, which is pretty common when you're not producing enough thyroid hormone. All that is required for treatment is just adding supplemental thyroid hormone. So taking a medication that will provide you with that additional thyroid hormone to replace the amount that is not being made naturally by the body. Any questions on endocrine before we move to reproductive? All right. So we'll talk a little bit about sexually transmitted infections. Sexually transmitted infections, abbreviated STIs, are infections that are caused by sexual contact with someone who is infected with one of, or two of, or three of these various conditions. Signs and symptoms are not always present, and also they differ between male and female. So, important to know in a facility, remember, residents have the rights to have their sexual needs met. So this is something that a resident might bring to your attention if they're experiencing symptom of a sexually transmitted infection. These infections can be passed through any sort of sexual contact. Some of them can also be transmitted during pregnancy or childbirth from mom to baby. Like I said, they cause a variety of symptoms, sometimes no symptoms, sometimes the symptoms differ between male and female. To reduce the transmission of sexually transmitted infections, the most effective measure is to use some sort of latex condom. Residents may be really embarrassed if they're experiencing these symptoms, so very important to know if a resident comes to you with some sort of symptom that could potentially be a sexually transmitted infection, that we take that seriously and report that to the nurse. So we'll go through a couple of them. Chlamydia is a pretty common one. Chlamydia, if left untreated, can cause pelvic inflammatory disease. Symptoms are typically burning with urination, as well as a white or yellow discharge from the genital area. Treatment is just antibiotics. More serious one, syphilis, if left untreated, can lead to severe brain damage. It can also damage other organs, especially the heart, the lungs, as well as, like I said, the brain. Syphilis, if it is left untreated, and we're talking untreated long term, not like for 2 days, if it is left untreated, it can lead to those more severe symptoms, but more commonly, what we would see initially would be some sort of rash or sore, as well as something maybe like a fever or a sore throat. Treatment for syphilis depends on the severity or length of infection. Can give penicillin oral, so taking it by mouth. Penicillin can also be injected. I can tell you from experience of injecting penicillin, it is not one that I personally would want to receive. Penicillin injections, it's a pretty large volume. It is a viscous or thick fluid that is inserted, and it goes deep into the muscle. So it's usually inserted with a longer needle. The administration of penicillin takes about 26 seconds. So for the insertion of the needle and then actually pushing that medication deep into the muscle takes an extended period of time. So for someone who has this sort of condition, if they're not experiencing super severe symptoms or they are not long into these symptoms occurring, usually they start with oral antibiotics. If the symptoms have been going on for longer and there's risk that maybe it has not been treated and it could potentially lead to the more severe effects, then maybe an injection will be given. Of course, that decision is really up to the doctor. Gonorrhea is another one very common. A lot of times the public health departments will treat chlamydia and gonorrhea at the same time. These two would be the most common that you would see, for example, in public health or maybe spreading between residents. So gonorrhea, if it's left untreated for an extended period of time, can cause sterility, so meaning no reproduction would be able to occur. Symptoms are different for men versus women. So men tend to have white, yellow, or green discharge and burning with urination. Usually women don't show any symptoms until later on, and then those symptoms include bleeding between menstrual cycles as well as cloudy discharge. Again, treatment for gonorrhea, just like chlamydia, is antibiotics. Moving on to genital herpes. Genital herpes is a little bit different than the others that we have talked about because it is actually caused by a virus. What's really important to know about genital herpes is that once someone is infected with genital herpes, that is now a chronic condition that will remain for the rest of their life. So it is something that cannot be cured. People who have genital herpes will have repeated outbreaks of the herpes, which will include red, kind of blistering, painful sores on the genital area during an outbreak. What is used to treat someone who has genital herpes who is experiencing an outbreak is an antiviral medication. Again, that antiviral medication is going to help with the outbreak, but it is not going to cure the genital herpes. If a pregnant woman is infected and has an outbreak of genital herpes at the birth of the child can become infected. So if mom was having an outbreak and went into labor, typically some sort of alternate method, like a C-section, would be used to remove the baby so that the baby is not exposed to that active outbreak of genital herpes and then ultimately infected for the rest of their life. HPV is caused by human papillomavirus, which is a different virus than herpes, also different than HIV. HPV is spread through genital contact with someone who is infected. It can affect both men and women. Typically, what you would see in someone who has HPV is genital warts. HPV can cause abnormal female exams, which are called pap smears. Can also lead to the development of cervical cancer later in life. Once someone is infected with HPV, there is no cure, but fortunately there are vaccines to prevent it from occurring. There used to only be a vaccine for females. There is now vaccination for males as well. That's like within the last maybe 7 or 10 years, I would say. So it used to just be females that could be vaccinated, but now it is both males and females. Keep in mind that sexually transmitted infections are disorders of the reproductive system. Those are the ones we just talked about. The ones we're going to talk about now are not sexually transmitted infections, but they are still conditions or disorders of the reproductive system. BPH, or benign prostatic hypertrophy, is a common one in older men. Usually starts to occur around the age of 60. And what happens is the prostate gland becomes enlarged. Enlargement of the prostate gland puts pressure on the urethra, which makes it difficult for the urethra to pass urine from the bladder to the exterior of the body. Treatments for this, typically medication. There's also a surgery that can go in and remove some of that prostate tissue. If you're not familiar with the prostate gland, I will show you a picture to give you an idea of where that is. So let me see if I can zoom this in. No, maybe. Nope. All right, well, we'll look at it anyway. So if you can see this, only males have prostate glands, if that wasn't clear already. So this would be the general male anatomy. The thing that is being shown in the middle there in blue is the prostate. So you can see if that prostate gland becomes enlarged, it's going to push on the urethra and decrease the size of the urethra. So urine is not going to be able to easily pass through. So most commonly, someone who is experiencing BPH, or benign prostatic hypertrophy, usually comes into the doctor saying that they're having trouble going pee. And that's usually because the prostate gland has become enlarged. Risk of prostate cancer also increases as we age. So again, since the only gender to have a prostate would be male, this only would affect males. It does not affect females. Prostate cancer grows really slow. It's also super responsive to treatment. So early detection is really important. So if someone is complaining about difficulty with urinating or having pain down in the area where the prostate would be located, those are things we would want to report to the nurse so that that can be further assessed. As far as female conditions of the reproductive system, vaginitis is something that can occur. So this is inflammation of the vaginal area, can be caused by a variety of different things. Typically it's bacteria. So BV, or bacterial vaginosis, is when there's an overgrowth of the normal bacteria. Usually symptoms are itching, burning with urination, and white discharge. There are medications that can be given orally, as well as creams that can be applied or inserted directly into the vagina. Vaginal irrigation, we're not going to talk about because first, it's not something very commonly done in healthcare facilities. And second, if it is done, it is not usually done by a nursing assistant. So we will skip over that. Honestly, in my own, how long? 10, 11, 12 maybe years in healthcare. I don't remember how old I am, but I started when I was 18. It's been a long time. In that amount of time, I have never seen an order for vaginal irrigation. I have never done vaginal irrigation, and I have never heard of someone having an order for a vaginal irrigation. So not very common. Any questions on any of those reproductive conditions? All right. Then we will move on to the immune and lymphatic systems. So As far as the immune system and the lymphatic system, remember they're closely related. So the immune system, as far as conditions that can occur with it, AIDS is one of them. Acquired immunodeficiency syndrome is what that stands for. Important to understand the difference between AIDS and HIV. So AIDS is actually the final stage of an HIV infection. When someone has AIDS, they are at a high risk of infection, unexplained tumors, central nervous system symptoms, and it's all a result of the weakened immune system that is unable to fight off all of these abnormal things. Someone who is in their later stages of AIDS can have what's called the AIDS dementia complex. It's a group of symptoms related to memory loss, paralysis, and confusion that happens as a result of damage to the central nervous system. So when we look at things that can occur when someone's immune system is weakened and they have AIDS or the later stages of HIV, opportunistic infections come up. So their immune system is so severely disabled that anything that tries to attack their system is going to be effective. It's not going to be fought off by the immune system. So since the immune system is unable to defend itself, those infections take that opportunity to invade the body and further cause issues. So again, AIDS is the later stage of HIV. So the AIDS virus or the HIV virus is responsible for AIDS. They are not two separate things. What happens when someone becomes infected with HIV is the infection disables their immune system. As they progress further and further through that immune system being disabled, those different symptoms that we talked about start to occur. So, how does someone get HIV? HIV is transmitted through sexual contact, contact with infected bodily fluids such as blood, use of an infected needle or accidental needle stick with an infected needle, and also from mom to baby. Usually when someone acquires HIV, the symptoms are not as severe as when they progress into AIDS. Typically, the symptoms when they get HIV are very similar to flu-like symptoms. It is not until the later stages, as they progress into AIDS, that they start to get opportunistic infections, tumors, AIDS dementia complex, etc. Other symptoms that you might see in someone, weight loss, pretty common, appetite loss. They can have some GI upset with severe diarrhea. Swollen lymph nodes are pretty common. Remember, as infections invade, those lymph nodes can get swollen. You can see different types of rashes on the skin. You may also notice night sweats. So when someone is sweating specifically at night, that is a symptom that we would want to report. That's not normal. Opportunistic infections like cold sores, fungal infections in the mouth, warts on the skin. They bruise easily. Their gums may become inflamed. They may bleed. They may have various different types of infections that invade their body. There's different types of pneumonia that they can get, as well as that complex that we talked about. So really important to know if you're taking care of someone who has AIDS, we need to be really strict on our infection prevention measures. There are a lot of different infections that maybe we can fight off because our immune system functions properly, that if these residents got, they would not be able to fight off, and they would then become infected and require additional treatments, medications, etc. So high-risk behaviors for contracting HIV. In healthcare, what we are concerned about is coming into contact with contaminated blood, bodily fluids, supplies, equipment, or sharps that could be contaminated with infected blood or bodily fluid. So how do we prevent the spread? How do we protect ourselves and other residents? We follow those standard precautions. We make sure that we're never recapping any sharps like razors or needles. We make sure that we follow a plan if we do accidentally come into contact with blood or bodily fluid, no matter if we know it's infected or not. We follow our facility's policy for what to do. We report that to the nurse, and then we follow whatever measures are in place. So, for example, when I worked in the primary care clinic, one of our doctors, who would probably be really embarrassed that I tell this story, recapped a dirty needle. And guess what? The dirty needle came through the side of the cap and poked him. So he essentially used a needle on a patient. When he was done with that needle, instead of just putting it into a sharps container, he tried to put the lid back on, and he poked himself. So in our facility, the protocol was that he had to, right then and there, stop what he was doing. He had to be evaluated by another doctor. He had to have lab testing. We also had to get a lot of information and consent and lab testing from the patient that had actually been poked with the needle first. And then we had a prophylactic measure in place in case the patient tested positive for any bloodborne disease or illness. So think about that. Think about that as you were handling sharps. Remember, they just go directly into the sharps container. Don't recap them. Don't try to put the little protective thing back on the razor. Just put it in a sharps container. Don't put yourself at risk because you're going to have to follow all of those lovely protocols. So myths versus facts about HIV and AIDS. I'll go through a couple of these. For example, know that if somebody has HIV, just shaking their hand or giving them a hug is not going to transmit HIV to you. You will not get HIV from someone else unless you touch some sort of infected bodily fluid or blood. Things like HIV can be spread by doorknobs or phones or tables. That sounds silly, right? HIV doesn't live outside the body. Unless we are touching an infected specimen of blood or bodily fluid, there's no risk of transmission. Same thing with the toilet. Everyone thinks that you can get things from a toilet. I remember when I was in high school and somebody was saying that if you used the toilets at school, you were going to get a sexually transmitted infection. That's hilarious, first off. Also, remember in high school, people saying that you could get pregnant from a toilet if you sat on the toilet and it had, some sort of secretion on it. It's like, okay, well, luckily for me, I have enough knowledge to know that that's not true. But same thing for HIV. You're not going to get HIV from a toilet. HIV doesn't live outside of the human body. It's not going to live on the toilet. So no need to worry about using the same toilet as someone who has HIV. So keep in mind that as long as you follow standard precautions, you don't need to worry about working with someone who has HIV or AIDS. There's no danger of transmission to you if you're following all of the protocols that are put into place to protect you. Also need to keep in mind that regardless of what condition someone has, we treat all people equally, right? We don't care if you have AIDS. We don't care if you broke your leg or you had a hip replacement or you had an amputation or you have, pneumonia. We treat everyone the same, right? We give everyone the same high quality of care regardless of what their condition. So following standard precautions, if there are any additional transmission-based precautions to follow based on maybe the person having an infection, follow those as well. Wash your hands, keep everything clean. Remember that these people are at a high risk of infection. Some people who have HIV and AIDS will have a decrease in their appetite, so they may be on like a high protein, high calorie diet, trying to maintain their weight. Residents who have infections in their mouth might be difficult for them to chew, to swallow. Pay special attention to giving good mouth care. Also, nausea is pretty common. So if someone's experiencing nausea, giving them smaller, more frequent meals can help with that. Also, ensuring adequate fluid intake is really important. Of course, reporting to the nurse if there is any change to the appetite or fluid intake, if they're experiencing nausea. If they have any issue with GI motility, diarrhea is pretty common. If they're experiencing any nervous system symptoms like neuropathy, things like loose fitting clothing, maybe slippers instead of socks and shoes. We can use a bed cradle, which we looked at previously, to help keep the sheets off the top of the toes and the legs. Also know that for someone who has a terminal diagnosis, meaning they're not going to receive a cure, they're ultimately going to succumb to the illness, it can be really depressing. They can experience a lot of anxiety around that. So we need to make sure that we're treating them with respect, providing them with additional emotional support. Also really important to remember, we don't want to be judgmental, right? We don't judge someone based on the condition that they have, how they got it. So we need to make sure that we're providing them, like I said, the same high quality level of care that we would be providing to anyone else. In Module 2, you looked at HIPAA. And one thing I want you to know about the status of someone, their medical diagnoses, including HIV or AIDS, is that that is protected health information, right? That's PHI. So we cannot share if someone has HIV or AIDS with anyone else. So for example, if their roommate said, hey, I just want to make sure that my roommate doesn't have HIV or AIDS or any sexually transmitted infections, we would not be able to share that information. We can just politely let them know that there are laws in place that protect people's privacy and that we cannot share that information. Now, if the resident comes to you and says, my roommate said that they have HIV, you would just say, I'm really sorry, but I can't talk about your roommate's health conditions. You know, if the resident wants to talk about that with their roommate, that's their choice. But we would not confirm or deny that with that resident. We would not provide any insight into that information because it is protected. If they have additional questions about that or concerns, you can always refer them back to the nurse, and the nurse can have a further discussion with them. There is a documentary, and it is on YouTube. It's called the Ryan White documentary. Type it in the chat. And you don't have to watch it, but it gives you a good idea of a little boy named Ryan White. Basically, he had a medical condition that required blood transfusions, and he got a blood transfusion before there were different testing and regulations in place, and he contracted HIV. So from a blood transfusion, he got HIV, and it's really interesting, it's really disheartening to watch how he was treated in his school and in his town as a result of having HIV. So if you want to, pull it up and watch it. It's on YouTube. You can watch it after class. If you don't want to, you don't have to. Just gives you an idea of kind of the stigmas around someone who has that sort of condition. All right. Any questions before we move on to cancers? No. All right. I want to show you this little picture if I can get it to pop up. Maybe. Yeah, it won't get any bigger than this. Oh well, I'll just show you this. So this, I saw this a really long time ago, and it resonated with me because, like I said, we're non-judgmental and we take care of everyone. So this says, I'm an ex-convict, I have AIDS, I'm a prostitute, I'm poor, I'm old, I'm gay, I aborted my baby, I'm a teen mom, I'm an alcoholic, I'm a beggar, I'm a drug user, I have cancer, I have a contagious disease. But the nurse said, I'll take care of you. So keep that in mind. You can put nursing assistant in there. That doesn't matter who someone is or what they do or what they have. We're going to take care of them regardless. All right, so cancer, The term cancer is very general. Cancer is a general description of uncontrolled growth of abnormal cells. So when someone has cancer, the way that we detect what type of cancer is basically where it is located or where it originated. When we say a tumor, this is a cluster of abnormal cells. Tumors can either be non-cancerous or benign, or they can be cancerous or malignant. When somebody has a malignant tumor, that just means that the abnormal growth of the cells is an abnormal growth of what we call cancer cells. General facts about cancer. Cancer does not have a cure as of right now. Cancer can start in one area of the body and it can spread or metastasize to another area of the body. Usually the first site of cancer where it first appears is either in breast tissue, the colon, the rectum, the uterus, the prostate, the lungs, or on the skin. There are a lot of different factors that go into determining risk of getting cancer. Genetic factors, lifestyle factors like tobacco use, alcohol, diet, physical activity, certain infections, also frequency of those infections, environmental exposures, as well as exposure to sunlight, specifically for skin cancer. The warning signs of cancer from the American Cancer Society include unexplained weight loss, fever, fatigue, pain, changes to the skin, changes to the bladder or bowel habits, a sore that appears and does not heal, unusual bleeding or discharge from any area of the body, thickening or a lump in a breast, the scrotum, or any other part of the body, indigestion or difficulty swallowing for no reason, changes to a wart or mole on the skin, as well as feeling hoarse or having a nagging cough, again, for no reason. Primary treatments for cancer, usually surgery, chemo, and radiation. There are other complementary therapies that can be done as well. Kind of depends on the stage of the cancer, the location of the cancer. So each case is different. Remember, cancer is a very general term. When we talk about taking care of someone who has cancer, residents will be on a wide variety of treatments or maybe not, which we'll get into tomorrow. Watch for signs of pain. Help to promote comfort, repositioning, heat, cold, back rubs. Residents who are receiving something like chemotherapy may have additional special measures, so follow the care plan for that. Encourage visitors, get to know resident interests, be alert to their unmet needs. Additional stresses or not having their needs met can make their symptoms worse. If you notice that someone is exhibiting signs or symptoms of cancer, you would want to make sure to report that to the nurse. So any of those warning signs that we talked about, or any worsening symptoms that they're already experiencing. For someone who has breast cancer, they may require a mastectomy, which we talked about in the chapter on vital signs. So mastectomy is removal of the breast tissue. The reason that we can't check a blood pressure on that side is because with the removal of that tissue also comes removal of the lymph nodes. So remember, our lymphatic system operates on muscle activity, breathing, and massage. So it does not have a pump. And if we restrict the vessels on that arm, they're not going to have anywhere to move that lymphatic fluid, which results in what we call lymphedema. So swelling as a result of that lymph fluid building up. So you don't need to get that technical. You don't need to know that process, but just to give you an idea of the why, right? Like, why can't I check the blood pressure on that side? That is why. These residents may also have special arm exercises ordered to help promote that movement of that lymphatic fluid. Deep breathing exercises, again, to help with movement of the lymphatic fluid. There are lots of different support groups available for people who have cancer, as well as their community, their caregivers, their friends, their family, whoever is in their circle. A lot of those resources can be found based upon where the person lives. The American Cancer Society has plenty of different resources to connect them to. Any questions on any of those chronic or acute conditions? No? Yeah, Samantha?
For a patient that had like a double mastectomy, where would you do the blood pressure for then?
You would ask the nurse. Usually, if they've had a double, they will have some sort of indication in their care plan as to where to check it. Sometimes it's a thigh blood pressure, which requires the expertise of the nurse to do. Sometimes the doctor will write like an override order that if you absolutely have to check the blood pressure, you can use one of the arms. For someone who maybe has heart disease and they need their blood pressure checked for medication, it should be specified. But if you're ever in question, just check with the nurse. Good question. That does happen. I've had that happen. I've had someone come into the clinic and it's like, oh, we can't check your blood pressure. And they're like, oh, they usually do it somewhere on my leg. And it's like, oh, okay. That makes sense. So then I would check with the doctor, confirm that was okay, and then proceed. Yeah, the thigh blood pressure is great, but the femoral and popliteal pulses are a little bit more difficult to find. So the nurse doing that sort of blood pressure check is usually what's preferred by the facility. Any other questions? All right, we'll go ahead and take our second break then, and then we'll come back and get started on chapter 19. So feel free to mute yourself, turn off your camera, and I'll see you